Thank you so much, Adrian. Thank you so much, Rupa, for inviting me to such an important subject about lymphocyte immunophenotyping as early biomarkers of inflammatory, autoimmune, neuroimmune, and neurodegenerative disorders. And the question in this class that we are going to ask is, why should we use the lymphocyte map in clinical medicine? Because LMAP can detect abnormalities at the pre-disease stage. That is the message of functional medicine and preventive medicine. Furthermore, we can detect abnormalities at early and active stage of the disease, not only just at the early stage, and finally, even at the progressive stage of the disease. So in the pre-disease stage, detected abnormalities provide a window of opportunity for early intervention. That's the most important message of this class today. Even during the active stage of the disease, an abnormal lymphocyte map can help practitioners to design personalized treatment protocols for their patients. Why? Because some may have abnormality at the T cell, another patient may have abnormality at the level of B cells. And therefore, the treatment or personalized treatment will be different from one patient to another patient. And finally, after treatment, follow-up LMAP can help practitioners to monitor the recovery of progress of their patients, whether or not the treatment, nutritional medicine, classical drugs could help the patient to improve the clinical symptomatology of the patient. So those are the most important parts of our class today. And let me share with you one of my articles that I wrote in 2021, followed by the second article in the same journal in 2022, that I'm sure all of you agree that genes plus environmental factors are responsible for development of all those disorders that I mentioned earlier: inflammatory, autoimmune, neuroimmune, and neurodegenerative disorders. And we call all these environmental factors together as exposome. So what is the exposome? The exposome is individuals' lifetime exposure to external and internal environmental factors. Let's have example: heavy metals, aluminum, pesticide. These are external environmental factors. But reactive oxygen species is the internal environmental factors. Therefore, the external and internal environmental factors plus genes play a significant role in induction of all these disorders. And of course, food, infection, toxic chemicals, and their effect on gut microbiome are the most important factors. But the issue about all these disorders, for example, autoimmunity, neurodegenerative disorders, they are not disorders or the disease that we go to bed and we wake up in the morning with the disease. So here you see, in relation to autoimmunity, we have different stages. And the green one is the healthy, silent autoimmunity, autoimmune reactivity, and finally, autoimmune disease. And getting from healthy to autoimmune disease, stage 3, sometimes takes 5 years, sometimes takes 10 years, sometimes may take 20 years. That's why LMAP is going to help us to detect disease at the silent stage of autoimmunity or even degenerative disorders. To support that, I would like to share with you this very important article with a very important message. This article was shared with me by our colleague, Cyrex clinical consultant, Dr. Mark Engelman, about a couple of months ago. Dysregulation and chronicity of pathogenic T cell responses in the pre-diseased stage of lupus. What this article emphasized is that change in CD4 positive T cells, especially T helper 1, increase, which they produce lots of interferon gamma, and decrease in the regulatory T cell, which both of them are part of comprehensive MAP by Cyrex, is involved in many patients with autoimmune diseases, including lupus erythematosus. And very elegantly, the message of this article was summarized in this figure, that in the left, you see the healthy state. In the arrow was the green color. Absolute balance between CD4 T helper 1 cells in red and regulatory T cell, which is gray. However, and that's ideal conditions because regulatory T cells keeps the balance of the immune system and inducing tolerance. No immune reaction against self-tissue antigens. But as I mentioned in relation to exposome factors, the epigenetics, genetics, and environmental factors can tip the balance in a favor of too many Th1, too few regulatory T cells, right here in the middle. And that results in initiation of autoimmune reactivity. Furthermore, if this will continue, meaning Treg insufficiency due to low level of interleukin 2 causes uncontrolled expansion of autoreactive T helper 1, which are involved in autoimmune diseases. Also T helper 17, which is not in here, could be also autoreactive. Expansion of Th1 and Th17 and communication between Th1 with B cells results in auto antibody production. Autoreactive T cell plus autoreactive antibodies can cause serious damage, resulting in autoimmune disease, in this particular case, systemic autoimmune disease such as lupus. So ideal situation is tolerance, but unfortunately, genetics and environmental factors can open the gateway or pathway to autoimmunity, then pre-disease stage, and finally 10, 20 years later, clinical manifestation. And so therefore, lymphocyte immunophenotyping is going to help us to find or to detect patient on the pathway to autoimmunity. And that's why it's so important to understand a little bit about the immune system and how the immune system works. As that immune system is classified as innate and adaptive immune response. The adaptive immune response also being classified as humoral and cell-mediated immunity. The humoral meaning any soluble materials we can find in blood or other body fluids, saliva, and more. Example, cytokines, chemokines, and of course, antibodies, which are produced by B cells, IgG, IgA, IgM, and sometimes IgE. So that is part of humoral immunity. In the case of cell-mediated immunity, we have three major types of cells that, but overall, are classified under T cells and natural killer cells, two types. And we'll talk a lot about natural killer cells and new additions of Cyrex about NK cell subpopulation. But T cells are divided to CD4 or helper cells and CD8 positive T cells or cytotoxic T cells or killer T cells. And CD4 T cells are subdivided to T helper 1, T helper 2, T helper 17, and Treg cells, which all of them have a significant clinical importance. So now we see that the innate immunity antigen presenting cells take up the antigen. Let's say this is Epstein-Barr virus, SARS-CoV-2, Campylobacter jejuni, will be taken up by macrophages. They release very strong enzyme called lysosome, breaking down the antigen, the pathogen to size called antigens, and the antigens will be presented on major histocompatibility complex to the T cells, and then T cells become activated in the presence of different cytokines, get different specialty, Th1, Th2, Treg, and Th17. Each one of them have different job in the immune system, and also they're involved in different disorders. So the questions here we are asking, why we need so many T cells? Th1, Th2, Treg, Th17, Th19, Th9, and follicular T helper cells that they are not in here, but these four are very important, clinically are very important. That's why I'm emphasizing. So the answer to that is because our body is exposed to diverse group of pathogens and antigens. Therefore, we need a diverse group of lymphocytes, in this case T cell, to respond to those variety of antigens. And each one of these T cells or B cells have specific cluster differentiation on their surface, as you can see. Some of them are general cluster differentiation. Some of them are highly specific to the type of cell that we are going to measure. For example, CD19, CD20 is highly specific to B cells. The other surface markers are general surface markers. They are not specific to B cells. So if we add monoclonal antibody to a drop of blood, that drop of blood can stain B cell with red or green or blue, and then flow cytometer will separate these cells based on their color, and computer will count the number of B cells in that drop of blood with very high accuracy and reproducibility. Now for CD, for T helper cells, I'm sorry. Can you turn this up? I'm sorry. There's some kind of alert through my cell phone, or the cell phone is up. Okay, so CD4 T helper cells, the cluster differentiation, as you can see, specific to this cell is cluster differentiation number 4, not the others. For example, CD45 or LFA or CD2. So therefore, we can stain CD4 with specific color and count that those cells with high reproducibility and accuracy. The same thing for cytotoxic T cell, the cluster differentiation is CD8. For using monoclonal antibodies stained with different colors, we can count the number of T cells, the number of B cells, Th1, Th2, Treg, and many natural killer cells with very high accuracy and reproducibility. The next type of cell is natural killer cell. As the name shows, that is a subset of lymphocyte, which is part of our innate immune system, meaning unconditional, can go after viruses and cancer cells. So they are a critical part of immune surveillance and defense against infection and cancer. How do they do that? By releasing all these missiles-like material, bullet-like material called granzymes, and by releasing those can break the membrane of viral infected cell and cancer cells, and within seconds can destroy viral infected cells and tumor cells. But everything else, there is balance is the most important, balance in the immune system. Because natural killer cells, if we have them certain number with certain activity, they are protected. But unfortunately, overactivation of natural killer cells due to infection and cancer also can promote a disease. So let's spend a little bit time on the protecting role of natural killer cells. Number one, they can clear damaged cells by releasing the bullet-like materials. Damaged cells by viruses can go after tumor cells, can kill immature dendritic cells because they are highly inflammatory, can eliminate hyperactivated macrophages, which also play a role in inflammation, can enhance the activity of regulatory T cell, and keep the balance between Th1, Th2, and Th17, can eliminate T helper 1 and T helper 17, and finally can enhance production of regulatory cytokines to inhibit Th1, Th17, and overactivation of B cells that results in production of autoantibody. So those are protective role of natural killer cells. But unfortunately, overactivation of natural killer cells can cause damage. For example, NK cytotoxicity can help, if too much activation of those can cause breakdown in tolerance mechanism, especially peripheral tolerance. Secondly, if there are cells in our body that antibodies produced against them, and those antibodies attach to those cells, the natural killer cell job is to go after tissue antigens or tissue cells that antibody is bound to, and through a mechanism called antibody-dependent cell-mediated cytotoxicity to remove those in order to prevent autoimmunity. Also, enhancing macrophage activity leading to higher levels of antibody production by overactivation of CD4 and CD8 cells. Natural killer cells can stimulate autoreactive CD4 and CD8. Both overactivation of these cells can contribute to autoimmunity. So to have too many NK cells, although their job is to remove viral infected cells and cancer cells and other cells being activated, their overactivation can cause damage to the tissue, contributing to autoimmunity. So now let's look at different NK subpopulation, which some of them are part of innate, some of them part of the adaptive immunity. The two cells that we are measuring, part of the Cyrex, are CD56 positive and CD16 positive NK cell. These could be measured separately or in combination. So that's one or two types of natural killer cells. They act like the army soldiers in our body. Then we have CD57 as part of innate immune system, CD57 positive NK cell. They act like rangers, also are highly specialized killers. Now, when rangers, CD57 positive cells, combine their activity with highly cytotoxic NK cells, CD16 positive cells, they become the Marines. These are highly specialized killers. And to the degree that I can make analogy of natural killer cytotoxic activity of a person could be measured by looking at CD57 positive, CD16 positive NK cell. So these are part of the innate immune system. How about part of the adaptive immune system? Yes, CD8 positive, cytotoxic T cells. These are not natural killer cells, but they are killer cells. They are called killer T cells. But CD57 also get combined with CD8 positive cytotoxic T cells. They become like Navy SEALs. And finally, we have a type of cells called NKT cells. They are T cells with activity of natural killer cells. These are CD57, CD56 positive, CD16 positive, and CD3 positive, meaning T cell with characteristics of natural killer cells. So we are going to elaborate more about each one of these because they're highly important. 6, which is, we call that NK cell, Cyrex report. CD56 bright, we call that CD56 positive, and CD16 negative or dim, meaning the monoclonal antibody is not staining the CD16, but staining very strongly for CD56 cluster differentiation. They are weakly cytotoxic, meaning they can kill to some degree viral infected cells and tumor cells, but they're highly regulatory T cell, regulatory NK cell, regulatory NK cell, and regulate the immune system. So under activation of CD56 positive, meaning immune dysregulation, overactivation of them also indicates overactivation of the immune system. The next one is opposite. CD56 is almost negative, but CD16 is highly positive. You can see the cluster differentiation of CD16 right here. These cells are highly cytotoxic, meaning that's why we call them cytotoxic NK cells, have the capacity to kill tumor cells and viral infected cells. So the next subpopulation of natural killer cells is CD57. Because of importance of this subtype of natural killer cells, we wrote with my colleague, Cyrex immunologist, this article in order to share with you, and hopefully you'll have time to read this article. So, as many practitioners are familiar with CD57 in relation of detecting so-called chronic Lyme disease by having low CD57. This claim was based on one article published in 2000, I believe, 1 or 2002, who found low CD57 in patients with chronic Lyme disease. But in 2009, fortunately, someone did studies and found that there is no relationship between CD57 and Lyme disease. Yes, there is relationship between CD57 low or high CD57 positive cells with pathogens and release of the antigens. And Lyme could be one of the thousands and thousands of pathogens. So therefore, please remember, this test could not be used for diagnosis of chronic Lyme disease, which I 100% agree with this. And it's wrong to use low CD57 as indication of Lyme disease and put your patients on medication, sometimes for 6 months, sometimes for years. And just think about how much damage we can do to the biome of that individual without any justification of putting that patient on Lyme disease based on, putting them on antibiotics for many years based on the false test, which is called CD57 positive step. So I hope I made my point about that. So yes, CD57 positive NK cell is marker protein found on surface of subset of NK cell. These are subset of highly cytotoxic lymphocyte, CD16 for NK cell, CD16 positive NK cell. They are highly differentiated, long-lived cells that are thought to be more efficient at killing their targets compared to the other NK cell subpopulation. During aging, their number are increased in order to protect us better against viruses, other pathogens, and tumor cells. So this is a summary of clinical importance of measuring CD57 positive NK cells in blood. So high levels of CD57 in the blood indicates persistent antigenic stimulation. That antigenic stimulation could be to antigens originated from the gut microbiome, could be from EBV, could be from SARS-CoV-2, could be from toxic chemicals that form neoantigen or antigens, which results in the alteration of the number of CD57 positive NK cells. That is why alteration in CD57 positive NK cells have been observed in the following major disorders, including viral infection, long COVID, myalgic encephalomyelitis, chronic fatigue syndrome, cancer, autoimmune diseases, toxic chemical exposure, chronic alcoholism due to neoantigen formation. For example, too much alcohol get converted to acetaldehyde. Acetaldehyde bind to albumin or hemoglobin, get into the liver, causing liver damage and activation of natural killer cells trying to get rid of too much neoantigen in the blood. COPD, chronic severe pain, transplantation, acute physical stress, and early pregnancy loss. So these are some of the major disorders that CD57 found to be high. Now, CD57 also collaborates with CD16 to become super NK cell killers, meaning a cell having cluster differentiation of 57 and cluster differentiation of CD16, they join together forces, they become the Marines of the human body. They are specialized killers of tumor cells, pathogens, infected cells, and many autoantigens damaging our tissue antigens. And then finally, CD57 positive cells form alliance with T killer cells, the CD8 positive T cells. And again, they become super killer. We call these the Navy SEALs of the human immune system. What is the clinical importance of measuring CD57 positive, CD8 positive T cells in health and diseases? Because increase in the number of CD57, CD8 positive cells is found in chronic viral infection and other pathogens, including EBV, CMV, herpes type 6, SARS-CoV-2, and many more. Increase in the number of CD57, CD8 positive cells is found in many cancers, including melanomas, head and neck cancer, and other cancers. In autoimmune diseases, the number of CD57, CD8 positive cells are highly elevated. In chronic pulmonary diseases, in physical stress, in chronic alcoholism that I explained before, the mechanism of action, finally, in transplantation, the increase in the number of CD57, CD8 positive T cell is in the body in order to increase immunosuppressive activity of the body and prevent rejection of the transplant. So that's why we have to measure all these NK subpopulation. And here we see example of cytotoxic T cell that kills cancer in the middle. There are 3 cytotoxic T cells with their bullet-like material in red are ready to release the bullet-like materials and kill tumor cells. And that's how the body becomes victorious against cancers. So now let's summarize the importance of NK cell subpopulation in protection against viral replication. When the virus gets into our body, if the immune system is not functioning, the virus is going to replicate exponentially, logarithmic. Okay? So that is dangerous because the virus is going to destroy the immune system. But thanks to immune system, okay, in here, so unconditionally, our innate immune system is going to produce a lot of interferon gamma. The names applies to interfering with the growth of viruses. So it's trying to stop the growth of the virus, and the virus is going to stop replicating And with the help of additional cells that you see now, so the immune system stopped by producing interferon gamma, stop the viral replication until the soldiers of the body, CD56 and CD16 positive NK cell, the US Army soldiers arrived to the site of the infection and destroyed the viruses. And therefore, when they finish their action, the number of viruses also will go down. If in case US Army soldiers could not finish the job, the next level is CD57, CD16 positive, the hot super killers, the Marines continue or come into the action and prevent the viral replication. And after 11 to 12 days, the virus replication of the virus completely is gone. And now the Marines and the Army soldiers can go back to their camp. Finally, we have another level of protection. In addition to CD56, CD16 positive, CD57 positive, CD16 positive cell, that is cytotoxic T cell. If in case that the Army and the Marines could not finish the job, the body is going to call the Navy, because it takes almost 6 to 10 days to get ready and have their ammunition ready to fight the infection. And finally, the subgroup of cytotoxic T cell, which is combination of CD57 with cytotoxic T cell, we call them the Navy SEALs. So it seems that interferon gamma plus CD56 positive, CD16 positive cells, US Army, the Marines, CD57, CD16, and Navy, CD cytotoxic T cell and cytotoxic T cells alliance with CD57 positive cells, the Navy SEAL, together are in our body to protect us against viral infection. And that's how the body becomes victorious against viruses and cancer cells. But what is the meaning of having low or high CD57 positive NK cell and its subpopulation? Lockup ability, low levels of NK cells indicate lockup ability of the body to protect itself against pathogens, cancer cells, and neoantigens. High NK cell and its subpopulation indicates that hyperstimulation of the immune system by pathogens, cancer cells, and neoantigens. And so when the numbers are high, meaning the body alerted the border patrols, the Army, the Marines, the Navy, the Navy SEALs to fight against in order to keep the homeland safe against the pathogens, cancer cells, and neoantigens. Ladies and gentlemen, after elaborating about the importance of NK subpopulation, let's review together the importance of comprehensive lymphocyte immunophenotyping offered by Cyrix Laboratories. I'm sure you know that many laboratories who do lymphocyte immunophenotyping, they look at T cell, they look at B cell, they look at CD4 cells, CD8 cells, and they look at CD56, CD16, and some of them may look at NK cell. But innovation of Cyrix is addition of calculation of the ratios, T helper 1, T helper 2, their ratio, Treg cells, T helper 17, and their ratio, and finally looking at CD3 positive CD16, CD57, its alliance with CD16, and CD57 with CD8, that we call them the highly super killers of the immune system. So you see, at Cyrus, we are doing almost twice more as what is done in other laboratories. And by the way, none of these could be replaced by looking at cytokine measurements. It is highly important to count these cells directly using flow cytometry, staining cells based on their cluster differentiation and color, where it gets separated. Laser will hit them based on the color, will be separated, and will give us the percentage of T cells, B cells, T helper 1, T helper 2, T helper 17, Treg, and NK cell subpopulation in less than minutes. So yes, we cannot measure Th1 and Th2 and Th17 and other cells by looking at cytokines. Why? Because let's take example of interferon gamma, which yes, it is classified as Th1 cytokine. But believe me, interferon gamma is produced by Th1 cells, but also is produced by some T helper 2 cells and T helper 17. So therefore, when you measure interferon gamma, is it produced by Th1, Th2, or Th17? And finally, some of these cytokines also produced by red blood cells and platelets. So when you measure cytokines, Th1 or Th2 or Th17, is it produced by that specific LMAP subpopulation or red blood cell or platelets? So that's why you have to measure the number of these lymphocyte subpopulation, the NK cell subpopulation, by staining cells directly and count them. So here, one example of a patient with early autoimmunity that we report now: the white blood cell counts, the lymphocytes, and the rest of the panel is depending on the number of the lymphocyte and percentage of the lymphocyte. So because in this case, the percentage of lymphocyte is high, the patient is having relatively high number of lymphocyte, and then that may have affected the number of T cells right here are elevated. The T and B cell ratio is high. The CD4 cells are elevated. That also is, depending on the number of T cells. And the number of cytotoxic T cells are within the normal range. And the CD4 CD8 ratio, the ideal situation for me is between 1.5 to 2.5. And this guy is having high CD4 CD8 ratio, very close to the higher level of reference ranges. And patient is having elevation in Th1 and therefore high Th1 and Th2 ratios. You remember in the beginning when I put those slides about in patient with lupus, those patients had high number of Th1 and normal or low number of regulatory T cells. And also this patient is having high Th17. So both autoreactive lymphocyte, Th1 and Th17, are highly elevated, and Treg cells are trying to fight against that, and the number are increased significantly in order to keep the balance between Th1 and Th17 and regulatory T cell. So finally, the patient is having high level of CD57, meaning the patient may have been exposed to some kind of antigens from bacteria, viruses, parasites, and so forth. So therefore, this patient is suffering from possible autoimmunity due to activation of Th1 and Th17 and also CD57 positive lymphocyte. There are many articles published in scientific journals that I'm showing only one slide in here, that when they looked at patients with rheumatoid arthritis, multiple sclerosis, scleroderma, and many other autoimmune diseases, when they looked at overall Th1, Th2, and Th17, they found elevation in Th1 and Th17 in many patients with autoimmunity. Not only abnormal Th1 and Th17, but downregulation or low number of regulatory T cells. When they treated patients with patients, then the number of Th1 and Th17 went down, the number of regulatory T cells went back, and that shows success in treatment modalities of patients with rheumatoid arthritis, multiple sclerosis, and patients with scleroderma, and many more that I did not show in this presentation, is shown in animal model and also in patients with autoimmune diseases, is the use of resveratrol. Resveratrol is known that repairing the gut barriers, the blood-brain barriers, and therefore can prevent also neuroautoimmunity. And in this case, in a mice model of autism, when they gave resveratrol in two different animal model of autism, could increase the number of regulatory T cells from 1.9% to almost double 3.3% in both cases. From, in this case, 1.5% to almost threefold, 4.4%. Resveratrol and many others nutritional remedies can increase the number of regulatory T cells and decrease the number of T helper 1 and T helper 17. So here you see decrease in the number of T helper 1, okay, from 3.1 to 2.1, from 4.5 to 2.8. If you combine these decrease with increase in regulatory T cell, this is highly significant, and you can observe that only by comprehensive lymphocyte immunophenotyping offered by Cyrex laboratories. What diseases could be associated with abnormal lymphocyte MAP in general, whether it is abnormal T and B cell, Th1 or Th2, Treg Th17, or abnormal NK subpopulation. First of all, multiple chemical sensitivity, allergies and hypersensitivity, long COVID, autoimmune diseases, chronic fatigue fibromyalgia, autism spectrum disorders, COPD, cancer, Alzheimer's disease, Parkinson's disease, heart disease, schizophrenia, and especially in the case of NK subpopulation, recurrent pregnancy loss. That's why I recommend comprehensive lymphocyte immunophenotyping. Final message for practitioners. Again, I'm showing this slide. Why should you use the LMAP in your practice? Because LMAP can detect abnormalities, at the pre-disease stage, the active stage, and the progressive stage of the disease, especially in the case of autoimmunities, Alzheimer's, Parkinson's, and many more. Detected abnormalities in the pre-disease stage provide a window of opportunity for early intervention. This is the heart of the matter, the most important message of this class. Also, during the active stage of the disease, the abnormal LMAP can guide practitioners to design personalized treatment protocols for their patients, whether that treatment is classical medication, dexamethasone, resveratrol, or naringeline. Finally, after treatment follow-up with these medications, the LMAP can help practitioners to monitor the recovery progress of their patients and examine the effectivity of specific medications or remedy used for their patients. And with that, I'll be very happy to answer any questions that you have. Thank you.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.